Hey everyone, and welcome to this explainer. Today, we're going to explore a deeply fascinating and honestly, a highly specific medical journey. We're looking at the evolution of conservative surgical operations designed to treat pelvic organ prolapse, specifically in young Indian women. It's a really incredible story of how a critical anatomical problem was met with decades of iterative mechanical innovation to finally find a lasting solution. Okay, let's dive into this. Here is our cognitive roadmap. We're going to follow a classic problem, solution, evolution arc today. We'll start with the prolapse epidemic in India, look at the shift to synthetic slings, discuss patient selection, map out the early sling pioneers, and finally arrive at the Verkud composite solution before wrapping up with our final thoughts.
Section 1. The prolapse epidemic in India. To really grasp the gravity of this issue, just look at this number, 5 to 8%. In India, the incidence of genital prolapse in young women who have just delivered 1 or 2 children is a staggering 5 to 8%. That is literally one of the highest rates in the world. And to put that into perspective, we aren't talking about postmenopausal women here. We're talking about young mothers whose reproductive lives are just getting started. The stakes here are absolutely crucial because any surgical fix has to preserve their fertility and their ability to bear more children safely.
So, what's driving this? Well, the root cause is something known as maternal depletion syndrome. It's a condition heavily tied to poor socioeconomic status. You see, many of these young women are anemic and malnourished, which naturally leads to poorly developed pelvic floor tissues. So when you combine this really fragile foundational tissue with the intense physical trauma of 1 or more vaginal deliveries, which, by the way, are often performed at home without modern medical support, the result is the devastating downward displacement of the cervix and uterus. It's an anatomical failure driven by systemic challenges, and it requires a highly specialized surgical fix.
Section 2. The shift to synthetic slims.
Now, what's really interesting about this slide is the paradigm shift it shows. For the longest time, surgeons tried using the body's own tissues, native fascia, like the rectus sheath, to try and literally sling the uterus back into place. But think about it, this native fascia is the exact same weak tissue that failed and caused the prolapse in the first place. It's like trying to fix a frayed rope with more frayed rope. It just stretches over time and the prolapse comes right back. The real game changer was ditching native fascia completely in favor of synthetic slings, like Merceline tape. These prosthetics are totally inert, they cause minimal tissue reaction, and they provide lifelong support.
Section 3. Patient selection and classification. Now, you can't just perform these sling operations on anyone. Traditional prolapse surgeries, like Fothergill's, actually involve amputating the cervix, which completely jeopardizes future childbearing. No way can you do that here. So the modern slings we're talking about have super strict criteria. They are exclusively for young women preserving their fertility. The patient needs to have a 2nd or 3rd degree prolapse, a uterus cervical length of under 5 inches, and virtually no cystocele or rectocele, which is a bulging of the bladder or rectum. If those bulges are present, they have to be completely repaired separately before a sling is even an option.
To make sense of the operations we're about to look at, Dr. Ajit Verkud gave us this brilliant classification cheat sheet. When evaluating any sling, you basically have to ask 3 questions. First, what's the position? Support from the front actually pushes the uterus backward into a bad, retroverted position. Posterior support is way better because it keeps the uterus tilted forward naturally. Second, is the support static, meaning anchored to bone, or dynamic, where it's anchored to the abdominal wall and moves with the muscles? And third, is the tape a closed loop or an open loop? This is a massive deal because closed loops carry a terrifying risk of postoperative valve obstruction if they happen to get too tight.
Section 4. The early sling pioneers.
And this brilliantly illustrates Dr. V.N. Schrodkar's operation, which he came up with way back in 1958. His whole goal was to recreate the uterosacral ligaments. If you look at the tape path, notice how it wraps right around the back of the uterus to create a posterior sling. It then anchors to the sacral promontory, that strong bony structure at the bottom, giving incredibly solid support. Now, anatomically speaking, Schrodkar's sling was brilliant. It provided excellent static support and kept the uterus pointing forward exactly like it should. But there was a massive catch. It was technically incredibly difficult to pull off. The surgeon actually had to navigate the sling through the psoas loop and under the sigmoid colons mesentery on the left side. This created severe risks of nerve injury. Plus, because it formed a complete closed loop around the pelvis, the risk of bowel obstruction was just a constant looming threat. So, realizing how dangerous that left-sided pelvic navigation was, Dr. Purandare swung in the exact opposite direction a few years later in 1965 with his cervicopexy. Take a look at this tape path. Instead of going backward to the bone, he anchored the tape forward, right to the anterior abdominal wall. Purandare completely solved the technical nightmare of Shirodkar surgery. It was way easier to perform, and it gave great dynamic support using those abdominal muscles. But you guessed it, he traded one set of problems for another. By pulling everything from the front, the operation yanked the uterus out of its natural alignment, tilting it severely backwards. This unnatural angle practically invited small bowel prolapse, or enterocele. And since the tape was anchored right over the front of the uterus, it posed a major hazard if the woman ever needed a C-section down the line. What followed over the next few decades was this rapid-fire medical quest to find the perfect middle ground. It's like a giant puzzle. In 1972, Khanna tried a neutral static approach, anchoring to the hip bones. But the tape sat way too close to the skin, causing severe pain and huge infection risks. Then Sonawala tried doing Shirodkar's operation, but only on the safe right side. Problem was, pulling from just one side completely distorted the uterus. Later, in 1993, Joshi tried anchoring to the pectineal ligaments. Great support, sure, but it meant operating in the retropubic space, a highly vascular area where one tiny slip could cause massive bleeding. Literally every single operation was a trade-off. Section 5. The Verkud composite solution. Let's move to and see how this builds into Dr. Verkud's composite sling operation from 1999. Look closely at the past of the tape here. It anchors to the strong, bony sacral promontory on the right side, taking a cue from Shirodkar. But instead of navigating that dangerous left side of the colon, the tape passes across the back of the uterus and then comes forward diagonally, anchoring to the left rectus sheath on the abdominal wall, totally taking a page from Purandare. This composite approach is just a masterclass in anatomical engineering. It gives the patient double support. You get static support from the bone, plus dynamic support from the muscle. Crucially, because it goes across the back of the uterus, it keeps the uterus anteverted, naturally facing forward, meaning it is perfectly safe for a future C-section. And the best part, because it travels diagonally from back right to front left, it's an open sling. The risk of bowel obstruction is completely neutralized. The only minor hiccup is that this diagonal pull kind of twists the uterus slightly to the right, a dextro rotation, but surgeons can easily fix that right then and there with a simple plication stitch on the left uterosacral ligament. Section 6, Discovery and Final Thoughts. So the crucial point is perfectly captured in this quote by Nobel laureate Albert Szent-Györgyi, which actually concludes Dr. Verkud's review. Discovery consists of seeing what everybody has seen and thinking what nobody has thought. I mean, for nearly half a century, surgeons looked at the exact same female pelvis, stared at the exact same ligaments, trying to solve this devastating problem for young mothers. It took iterative thinking, learning from the tight closed loops of Shirodkar, the flawed angles of Purandare, and all the complications of everyone in between, to finally visualize a diagonal, open loop pathway that solved the whole mechanical puzzle. It's a profound reminder of how medical innovation really works. It's not always about inventing some crazy new technology. Sometimes it's just about looking at an old problem from a completely new angle. It really makes you wonder, what other unsolvable medical conditions are out there right now just waiting for someone to finally draw a diagonal line? Thanks for joining me on this explainer, and we will see you next time.